Hello everybody. Today we'll be talking about infective endocarditis. So before we move on, I'd like to mention about the people who are at risk for infective endocarditis. These are people who have valvular heart disease like rheumatic heart disease, mitral valve prolapse, congenital heart disease like aortic and pulmonary stenosis, bicuspid aortic valve, VSD and PDA. People who have a history of injection drug use, this generally leads to a right-sided infective endocarditis. People with poor dentition, indwelling intravascular devices like IV catheters, presence of prosthetic valves, cardiac implantable devices, and patients who are on chronic hemodialysis, because these patients usually have chronic intravascular access and they also have impaired immunity, which increases their risk for infective endocarditis. Coming to common organisms, so when you suspect few organisms, you have to think of a few conditions associated with them. For example, Staph aureus, you think of IV drug use, native valve infection from sepsis, so that means the infection could be somewhere else in the body. Then the presence of prosthetic valves, presence of implanted devices, and intravascular catheters. So all of these conditions must be thought of if the organism is Staph aureus or even vice versa. Next is for Staph viridans, we have to think of conditions like dental procedures. Usually it is through dental procedures that Streptococcus viridans affects the heart valves. Coagulase negative Staphylococcus like Staph epidermidis is usually, they cause infection in prosthetic valves and intravascular catheters, also implanted devices. Finally, Enterococcus, you have to think of UTI or any genitourinary procedures. Streptococcus galolyticus, you have to think of the presence of colon carcinoma or inflammatory bowel disease, which is why usually a patient with a strep galolyticus infective endocarditis should be followed up with a colonoscopy. Fungus is also an important cause of infective endocarditis, so we have to think of presence of intravascular catheters, immunocompromised host, and prolonged antibiotic therapy. All of these factors predispose to fungal infections like Candida. Now, the most common cause of healthcare associated IE is Staph aureus, whereas the most common cause of community acquired IE is Streptococcus. Also, you do have a group of organisms, the HACEK organisms. These are fastidious gram-negative organisms like Haemophilus aprophilus, Actinobacillus, Cardiobacterium hominis, Eikenella corrodens, and Kingella kingae. So these are rare causes of infective endocarditis. So coming to clinical features, they can be quite non-specific or they can present with fever, that's the most common. The patient can have chills, anorexia, weight loss, and this is important. The presence of a new cardiac murmur is an important finding in IE. Certain important signs that we see in infective endocarditis, this is quite important. There are Janeway lesions, ossular nodes, rot spots, splinter hemorrhages, splenomegaly, glomerulonephritis, septic emboli to organs. So I'll just talk a few words about each. So Janeway lesions are actually an example of embolic phenomena, and these are basically non-tender erythematous macules on the palms and soles. This is important, they are non-tender. Ossular nodes are caused because of immunologic phenomena, so that's because of the antigen-antibody complexes. Ossular nodes, on the other hand, are tender subcutaneous biliaceous nodules on the pads of fingers and toes. Rot spots are also because of immunological phenomena, and these are essentially hemorrhagic lesions on the retina with a pale center. Splinter hemorrhages, again because of an embolic phenomena. Splenomegaly is caused because of an embolus to the splenic artery, leading to either splenic infarction or if the septic embolus goes into the spleen, it can lead to a splenic abscess. Glomerulonephritis is an immunologic phenomenon due to deposition of antigen-antibody complexes in the glomerulus. And finally, because of septic embolus to organs, an intracranial septic embolus can lead to an embolic stroke. It can lead to intracranial abscess as well. And right-sided infective endocarditis leads to septic pulmonary embolus. Now, this is the criteria that we use for infective endocarditis. That's really important, is the Duke criteria. So here we have major criteria and minor criteria, and depending on the number of each present, we can say if the possibility for infective endocarditis is high or not. So the major criteria includes blood culture that is positive for a typical organism, that is Staph aureus, Enterococcus or Streptococcus viridans. These are the top 3 organisms that cause infective endocarditis. The second is the presence of valvular vegetation on an echo. Coming to the minor criteria, these are a predisposing cardiac lesion already present in the patient, history of injection IV drug use, presence of fever with a temperature more than 100.4 Fahrenheit, presence of embolic phenomena like we mentioned, Janeway lesions, splinter hemorrhages, stroke and acute limb ischemia because of embolic spread into the vessels, presence of mycotic aneurysms, and septic infarcts in the spleen and lung septic infarcts as seen in case of right-sided IE. Next, the fifth is immunologic phenomena like Roth spots, Osler nodes, and glomerulonephritis. And finally, positive blood culture, but not that meeting the major criteria. So this is a blood culture for other organisms, not the typical organisms. So finally, with both of these criteria, we can say that we can define it as definite infective endocarditis if there is a presence of 1 major plus 3 minor criteria, and a possible infective endocarditis if it is 1 major and 1 minor, or the presence of 3 minor criteria. So that's with Duke criteria for infective endocarditis. Now suppose a patient comes with a suspicious IE. What is the algorithm we follow? First, you determine if the symptoms are acute or chronic. If they are acute symptoms that have been present only for 1 or 2 days, we have to think of the following. It's most likely a staphylococcal or streptococcal infection. Patient is usually very acutely ill, and you may not find all the immunologic phenomena that we discussed about because there hasn't been enough time for those to demonstrate itself. So what we do next is we take a blood culture stat. And how do we take the blood culture? This is important. We take 3 sets from separate venipuncture sites. 3 sets, and they should be from separate venipuncture sites. Each set must have 1 aerobic and 1 anaerobic bottle, and blood cultures have to be collected before you begin antibiotic therapy. And after we collect the blood culture, we will start empiric antibiotic therapy. Now suppose a patient comes with chronic symptoms that have been going on for weeks. For example, you have to think of organisms like Streptococcus viridans, Enterococcus, and the Hayseck organisms. These cause more of the subacute to chronic infective endocarditis. So these patients are usually not acutely ill, and they may have all the immunologic phenomena that we talked about because there has been enough time for those to present. So in these cases, again, we start with blood cultures. But if the patient is not very ill, we can start antibiotics after we get the culture reports rather than starting an empiric therapy that we did like in acute case. And finally, we go for imaging, that is either a transthoracic echo or a transesophageal echo. So coming to the imaging part, we usually for patients we begin with a transthoracic echo, and then If it is a positive transthoracic echo, we will correlate these echo findings with microbiological findings, and we basically put all this into the Duke criteria. Now, in case you have high risk echo features like the presence of very large or mobile vegetation, or severe valvular insufficiency, or a paravalvular extension like formation of a perivalvular abscess. Now, these are high risk features, in which case you want to see those complications much more clearer, and that's why we go for a transesophageal echo after this. So you want to see those, for example, a perivalvular abscess is seen much better in a TEE than a TTE, so we would follow it up with a TEE in such high risk cases. Now suppose a TTE was negative and we have a pretty low suspicion for infective endocarditis, then we can just go for an alternate diagnosis. But if our suspicion is high, now what do I mean by that? I mean, I have a high suspicion for infective endocarditis if it's a Staph aureus infection, if the patient has a new murmur that was not present before, if the patient has a history of infective endocarditis previously, if the patient has congenital heart disease, presence of any prosthetic valve or any intracardiac device. Now, these are all features that increase my suspicion for IE. So in those cases, even if it's a negative TTE, I'll go ahead with a TEE. And if it's a positive TEE, again, we will correlate these echo findings with our microbiological findings, put it into our Duke criteria to find the possibility for infective endocarditis. Now here I'd like to talk a bit about imaging in IE. So when I say a positive echo finding in IE, I mean the presence of vegetation or abscess or a new dehiscence of a prosthetic valve. And as I mentioned, TTE, that's transthoracic echo, is usually the first diagnostic test that is done. TEE has a higher sensitivity than TTE, and it's better for detection of cardiac complications like abscess, valve leaflet perforations, pseudoaneurysms. All of these can be better visualized on a TEE rather than a TTE. And there are a few conditions where we prefer to do a TEE. So first is, as I've mentioned, if the TTE was negative but I still have a very high suspicion for IE. If the TTE was positive but there are very high risk echo features or presence of complications which I want to look into further. And also, if I see that there is very significant valvular regurgitation and I'd like to assess the need for surgery for the patient, in those cases as well, we will go for a TEE. Now coming to the antibiotic regimens that we follow for IE. Empiric treatment is given to those patients who are unstable or those who have an acute IE. Empiric therapy should be given only after 3 sets of blood cultures are drawn. And empiric therapy usually covers MSSA, methicillin sensitive Staph aureus, MRSA, Streptococcus, and Enterococcus. In case of native valve infective endocarditis, the regimen is a combination of vancomycin and a beta-lactam, which could be either ceftriaxone or cefepime. In case of prosthetic valves, the combination is that of vancomycin, a beta-lactam, but we will also add gentamicin and rifampicin, so these two are extra. Now, there are targeted antibiotics depending on the microorganisms. For MSSA, we'll go for oxacillin or nafcillin. MRSA is vancomycin. Enterococcus will be ampicillin with gentamicin. For the HASEC organisms, ceftriaxone is the drug of choice. For Streptococcus viridans, we can use either ampicillin or penicillin. Now this is important. We obtain follow-up blood cultures 48 to 72 hours after antimicrobial therapy, and this has to be repeated every 48 to 72 hours until the clearance of bacteremia, and when that clears, that is when we can stop our antibiotic regimen. Now, this is a very small a note on culture negative IE. So, this is basically infective endocarditis without an etiology. We find there is no growth after 3 blood culture samples in standard culture systems are grown. We find no organism, and basically that's negative cultures after waiting for 7 days. And usually the common causes for culture negative IE are Coxiella burnetii and Bartonella. But again, you have to keep in mind that cultures can be negative if you're taken those cultures after starting antibiotic regimen. In that case also it could come out as a culture negative IE. Now the next slide, I will be talking about the complications associated with infective endocarditis. First one being heart failure. Heart failure is the most common cause of death due to infective endocarditis, and usually heart failure is due to severe valvular insufficiency, which is caused by valvular damage by the infectious organism. Second is perivalvular abscess. So this can present as conduction abnormalities on ECG because of involvement of the conduction system, and this can essentially lead to a heart block. And as I had mentioned before, a transesophageal echo is more sensitive than a transthoracic echo for abscess detection. Now, basically, these perivalvular abscesses occur around the aortic valve usually, and this is where the interventricular conduction fibers of the proximal conduction system of the heart is located. So if that gets damaged, you can imagine why this would lead to conduction abnormalities and heart blocks. The third is systemic embolization of the septic embolus. So if it goes into the CNS, it can lead to stroke. It can spread to the spleen or the kidney, leading to infarctions. It can spread to the eye, leading to endophthalmitis. Eventually, that can lead to blindness. And right-sided IE can lead to pulmonary embolism as well. The fourth is abscess. So if it depends on which organ the septic embolus goes to. So it can lead to CNS abscess, splenic abscess, and then mycotic aneurysm. So mycotic aneurysm is basically when the septic embolus actually goes and infects the arterial wall. So it can lead to the damage of the wall, thereby leading to wall weakness, and that can eventually lead to dilatation and formation of an aneurysm. And sixth is glomerulonephritis. That is because of antigen-antibody complex deposition. That's an immunologic phenomena leading to glomerulonephritis. Now, when do you consider surgery in IE? So apart from the antibiotics, when do you do surgery? So if the patient has acute heart failure due to severe valvular regurgitation, you have to do surgery of those valves. If there's extension of infection into a perivalvular abscess or a fistula, eventually even leading to heart block, those patients need surgery. If the organism is very resistant, like a multi-drug resistant pathogen that's not going to be treated with your usual antibiotics, then surgery is warranted. Persistent bacteremia despite being on maximum antibiotics. The presence of a very large vegetation and presence of persistent septic embolus. These are conditions where we do surgery. Now coming to the prophylaxis in infective endocarditis. Now to prevent an IE, what must the prophylaxis be and who should receive this antibiotic prophylaxis? So patients undergoing dental extraction, this is important, dental extraction, but only along with the following features must receive prophylaxis. What are these? A history of previous infective endocarditis, unrepaired congenital heart disease, presence of prosthetic valve, a repaired congenital heart defect but with residual defects, history of cardiac transplant. So these are the list of patients who must receive antibiotic prophylaxis, and the regimen that we follow is oral amoxicillin 1 hour prior to the procedure, or if the patient has an allergy to penicillin, we could give intramuscular clindamycin 1 hour prior to the procedure. So this is the prophylaxis regimen that we'll follow to prevent infective endocarditis. So that is with our video with infective endocarditis today. Thank you, and I hope you enjoyed it.